Moeller is going to be presenting on this very important topic. Guys, this is something we need to start talking about because I think approval is coming for these medications. And if we're going to offer it to some of our patients, we need to start planning. Okay, so today's topic, as highly anticipated, is our monoclonal antibody therapies to treat Alzheimer's dementia. Specifically, are we ready to step into the future with these disease-modifying treatments? And first step is developing literacy, right, in this evolving area, and second step is planning. So we'll have all those discussions. So the ones that we are talking about today are the ones with positive phase 3 studies. So aducanumab, lecanemab, and donanemab. So Dr. Moeller gave me first try at tripping over these names, right? That's why he wanted me to introduce this slide. So these are the trials that we'll be talking about. So today is really Dr. Moeller who's spearheading this conversation today. He took the lead on this, and he actually wanted me to talk about his qualifications to present on dementia, which I don't think needs to be done, but he has prepared a handy slide. And I just also wanted to say at the end of the presentation, it will be Dr. Alan Huang who will be moderating the Q&A discussion. For the Q&A part, guys, instead of putting into comments because we can't actually see the comments from here, please raise your hand. Liz Lacasse will be moderating that and letting you know when it's your turn to speak up, okay, and ask the question. Okay. So without further ado, I'll introduce Dr. Frank Moeller. So we all know him as, actually, you edited this because we all know him as a professor of medicine in our division of geriatric medicine and, of course, a geriatrician here. So I didn't actually know this. Back in 1993, he presented at Medicine Grand Rounds on the first cholinesterase inhibitor, Tacrin. Now, I only know this from, I think, research studies from the past, never used it. Dr. Moeller, of course, as a clinician, has been providing care for people with dementia for almost 30 years. He has had more than 160 dementia-related presentations. He has done a master's in epidemiology with the thesis of derivation and validation of cognitive screening tools. He was involved in the development of Ottawa 4DY and also of 3DY, of course, which is used in our emergency departments every day. He's past co-chair of the Champlain Dementia Network. He's a past dementia and driving researcher, and I know this personally because he supervised my research project back in the day. He's co-author of the Canadian Medical Association guidelines on dementia and driving. And as a member and president of the Canadian Geriatric Society, he presented on dementia to some very important committees. So the Federal Senate Committee reviewing the need for a national dementia strategy, and also to the House of Commons Standing Committee on chronic diseases. He has, of course, also contributed to provincial and national dementia strategies and guidelines, such as the PHAC Dementia Guidance Initiative, Alzheimer's Society of Canada, Ontario Ministry of Health, and he has been the investigator or co-investigator on 19 dementia-related grants, and he has authored or co-authored more than 70 dementia-related publications. So I think that stands to say you're qualified to speak on this topic, Dr. Moeller. The last thing to mention is that in 2009, he published a systematic review in JAGS on the minimally clinically important difference, MCID, of dementia randomized control trials outcome measures, which will be very important in our discussion today as we go through this topic. Okay, so here we go. The floor is yours, Dr. Moeller.
Thank you. I keep trying to set my timer and it keeps switching to 30 minutes. I think my phone's trying to tell me something. Hurry up. So this was not for people who know me. There are other people who are attending who've never heard of me. It's to give them a sense that I can talk on this topic. I'd really like to acknowledge the cognitive neurologists from Gruyere, Andrew Frank and Neil Thomas, who are here. They provided a ton of support for this talk, sent me the papers, sort of brought me up to speed on the science. So that's been hugely helpful, and I think we're going to continue to have a little think tank and try to get a handle on the science. Our neuropsychologists, Dr. Delamalva and Dr. Santos, helped me with some of the MCID measures. There's a lot more minimally clinically important difference measures we're going to have to work on. And this is the absolute worst time to give this presentation when half my divisions just come back from the dementia conference and had heard all these talks. So you're going to tell me what I got wrong and what I got right. but I may approach this from a slightly different angle than other talks you've heard about. Conflict of interest, I've been giving cholinesterase inhibitors since the late 90s. I think about 25 to 50% of people slow down or stop temporarily on these medications. I think some of the people we're treating as Alzheimer's don't have Alzheimer's. They have some other type of dementia like late limbic predominant age-related PD43 encephalopathy, which some people say exists, some say doesn't exist. While I prescribe the medications, I have pushed back on some of the research saying the RCTs have to be analyzed more appropriately and more carefully, and this presentation will be along that vein. And I have published a systematic review looking at the measurements in dementia drug trials indicating most are invalid because of a technique called last observation carried forward, and brought that to the FDA, EMA, and Health Canada. So I believe the drugs we have work. I have pushed back. I don't accept anything from pharma, but I have met with Lilly recently. So I think we all feel we try to establish some sort of balance. So hopefully you'll feel that way at the end. So objectives for this talk are really to better appreciate the concept of minimally clinically important difference. This is not an esoteric statistical technique. This is the very basis of whether a trial is positive or negative. It's something that should be taught, almost day one in medical school. It's sort of a missed or gap in teaching. I want to help you develop a deeper understanding of the benefits of the drugs, factoring in the MCID and the costs and risks. So you're going to see me go on either side of the issue as we go through the presentation, and then give the group a sense of how much collaboration we're going to need between specialties and across organizations. So busy slides, so minimally clinically important difference. Malcolm Hain, Dean Ferguson, and I published on this in 2009. The measures we looked at then have all changed. So they're not the measures that are used in the trials now, but we have some experience with this, and we're putting together a group to look at MCIDs again. It's important to differentiate statistical significance from a clinically important difference. So statistical significance means mathematically you can tell the two groups apart, right? It might be minuscule, might have no meaning, but you can tell it apart within a reasonable, acceptable margin of error. So it may not mean anything. Clinically important difference, or minimally clinically important difference, is the smallest change in an outcome that a patient would perceive as clinically meaningful. Now that's in the absence of cost, inconvenience, or side effect, but it's a higher bar. It's sort of the bottom bar that RCT should cross. It's not just statistical significance. And it really warmed my heart when I looked at these trials to see MCIDs have now been integrated. Back in the day, it was very rare to see people actually talk about clinical significance, or if they did, it would be their own opinion, sometimes after looking at their own data, which is not very valid. When you look at the MCIDs, be aware the ones I quote are the best we could find for now. We're going to dig deeper. They may be wrong. Okay, so take them with a grain of salt. Ask yourself, where did these come from? Because we don't really know. We have to dig deeper. They don't counterbalance with cost, inconvenience. They can't, because they weren't derived within the study, so they wouldn't have that information. But they are a better bar that we should cross. So I'm wondering whether we have to adjust MCIDs, or whether this information, cost, inconvenience, side effects, you would build into decision tools. I'm kind of now today leaning towards decision tools. In one of the trials, in the Trailblazer trial, you're going to see the concept of meaningful within patient change. I think that means MCID. I'm not sure. I'm going to treat it as MCID for this talk. But if you have corrections to make, save them for the end, and then I'll go hide in the corner and you can correct away. So the first drug that came out, all of these drugs target amyloid. The first one that came out was aducanumab. So this is the first drug that has been approved, I think, since 2003 for Alzheimer's. There's been, a drought for 20 years. So this targets amyloid. There were two studies. There were two phase 3 trials, Emerge high dose and Engage low dose, that were stopped halfway through. Afterwards, subsequently, they did a post hoc analysis that found some positive findings in Emerge that I'm going to talk about. So a lot of people see this post hoc analysis and they absolutely freak out because post hoc analyses have a bad name. Often what they mean is people are data dredging. They're going through their data, looking at multiple types of analysis. I don't think this is what happened here. So I think what happened here from my reading is Engage Emerge started in 2015. They continued until December 2018, which was a pre-scheduled interim analysis. So they stopped that, they collected that data, set it aside for analysis. They continued to enroll patients. Patients were still getting treatment. It took about 3 months, December 2018 to March 2019, for them to analyze the data. And on March 2019, they found there was insufficient positive findings to continue the trial. So they stopped the trials based on a futility analysis. I think that was premature because then what they did is they said, wait a minute, in between December 2018 and March 2019, a lot of patients actually finished the trial. So in Engage, 139 finished the trial, 12% more. In Emerge, 179 more finished the trial, 18% more. So the trial essentially continued without any changes. Then they reanalyzed at that point, and they found, lo and behold, Emerge actually had positive findings. So I don't think this is the traditional post hoc analysis that we all love to hate. This, in my mind, was a trial that was discontinued too quickly. So if they had let it go longer, they might have found more. So in Emerge, the high dose trial, they found the CDR sum of boxes. There was a change, a positive change of 0.39. Now we'll talk about CDR sum of boxes. 0.39 on an 18-point scale may not be a lot. So this might be a statistically significant positive finding, not crossing the MCID. So to my mind, one of these trials is positive, and they removed amyloid. So they were both positive in terms of removing amyloid. This caused a huge firestorm. What happened in FDA is the advisory committee reviewed this, and 10 members of the advisory committee said they were not supportive of this drug being approved, and one abstained. The Office for Neurological Drugs Assessment said it was positive, so I think they hung their hat on the removal of amyloid. So one positive trial and the removal of amyloid. Statisticians were negative, so there's a lot of conflict within FDA. So aducanumab did receive accelerated approval from FDA, and there was huge controversy because it was really one positive trial with post hoc analysis, which I feel is a valid post hoc analysis. So the question is, are we not, accepting two positive phase 3 trials, which was the old standard? Have we changed the standard? Now, reading up on this some more, looking at Cummings' writings, what may be happening is one phase 3 trial is being approved. The drug is being given accelerated approval with the understanding it has to prove itself on a second confirmatory trial after approval. So this is a whole new thing. I've never heard of this before. Other writers have said that's a little dangerous because the results of the next trial could take 3 years, 5 years, 6 years, 8 years while we're using this expensive drug. So that's a slippery slope. And then once it's part of standard practice, can you really withdraw it? So it's hard to tell what's going on here, but huge firestorm. We had a consortium in Canada that are a Canadian consortium for neurodegeneration in aging, CCNE, convened multiple organizations, the C5R, the Canadian Academy for Geriatric Psychiatry, Canadian Geriatric Society, Ontario Neurodegenerative Disease Research Initiative, Toronto Dementia Research Alliance. So they brought together a bunch of researchers, a lot of familiar names here: Churchow, Hogan, Rockwood, Montero, Dasso, Black, Bory, Feldman, from many of our specialties. And they highlighted a few things. Number one, all the relevant data wasn't available in 2021. It wasn't published. FDA had it, maybe Health Canada had it, but it wasn't available. They highlighted the FDA advisory committee really not agreeing with release. They highlighted that 2 successful phase 3 trials had not been completed. And as I said, that may be a new way of doing things. One phase 3 and then a confirmatory in situations where we have awful diseases with dire outcomes. So dementia is a horrible, horrible disease affecting millions of people. So, there's a lot of pressure to get some treatment. They were really against the post hoc analysis. I'm not as negative about it. They did point out that just removal of amyloid in the brain is not an outcome, as they put it. It's evidence of lowering amyloid levels within the brain would only be sufficient if amyloid was a demonstrated and accepted surrogate measure for dementia progression or reversal, and it's not. What you're going to see on all the charts I show you is a lot of amyloid is removed from the brain. There's continued progression, but slower. So I think amyloid is part of the picture. It's probably not all of the picture. That's a signal it's not complete. They recommended another trial, and I believe Envision phase 3's trial is ongoing. The RAND Corporation, and I just heard Dr. Frank, you presented on this. They presented on, or they wrote an article on how unprepared we are as a society for these drugs. So we don't have enough specialists or memory clinics. We've known that for years. We don't have enough MRI, and these apparently would be thin slice MRIs that would need different protocols and different training. These would have to be done when you start therapy, right after starting, whenever you have any neurological symptoms, headache, dizziness, grogginess. So we don't have the MRI capacity. The diagnoses in these trials was Alzheimer's, MCI, mild cognitive impairment, and dementia. So you need amyloid for that, either on PET or CSF. So we don't have the capacity to do that. So they really showed that we do not have the capacity to do this right now. So in May 2021, Biogen asked Health Canada for approval. It was not given. I believe in Europe it wasn't given either. Is that correct? In the US, it has been approved. I think it's been used in fewer and fewer patients in a very restricted fashion. Envision phase 3 trial coming, so we'll probably see more of this drug. So that's 2021. Do we have better monoclonal antibodies now? So 2 more have emerged, and I'm going to trip over the names: lecanemab, or Leqembi, donanemab. The healthcare system itself hasn't changed, or if it's changed for the worse, right? There isn't a lot of money kicking around the system. Something to keep in mind. So as we look at these 2 drugs, I'm still not sure what's happening. Are they accepting a phase 2 and a phase 3 now instead of 2 phase 3s? Or are they accepting a phase 3 accelerated approval with the understanding there will be a confirmatory phase 3 after, maybe many years after? But what are phase 1 and 2? So phase 1 trials are pharmacokinetics, pharmacodynamics, measurement of the maximum tolerated dose. How much can people tolerate? Phase 2, you take the maximum tolerated dose and you see, does it work? At its highest tolerated dose, is it safe? Phase 2B, you start to get lower doses to see, is there a lower dose that's than the maximum tolerated that gives you almost the same benefit with fewer side effects? You find a nice dose, and then you do a phase 3 trial on it. So that's the normal way things are done. So in lecanemab, there was a phase 2 trial published in 2021 that aimed to get about 90% effectiveness of the maximum tolerated dose over 12 months on the Alzheimer's disease composite score. A priori, they said they needed 80% probability of greater than 25% reduction. So they randomized 854 patients. So I said, wow, that's almost a phase 3 trial. It wasn't balanced, more lecanemab than placebo, as you can see, 609 versus 245. And at 12 months, the 10 milligram per kilogram biweekly, which means every second week, dose had a 64% probability of better outcome by 25% on ADCOMS. So they were aiming for 80%, 64%. To me, it looked pretty good. I said, wow, that's splitting hairs. But in fact, this was a dose-finding study. So what happens in a dose-finding study is you get multiple different doses, right, with smaller ends. So if I'm reading the trial correctly, the 10 milligram per kilogram biweekly every 2-week dose was the bottom row, the one that has a sample size of 28. So this is how a phase 2 trial should run. Phase 2B trial, this is what they look like. Then you get your best dose, so 10 milligrams per kilogram biweekly, and you run that through your larger phase 3 study, the way it's supposed to be done. But this is not a lot of evidence for the drug on its own, right? This is a very small n. So phase 2, now into phase 3. So this was a big study, 18 months, multi-center, looking at early Alzheimer's, which could be mild cognitive impairment, mild dementia, with amyloid and on PET scan or in the CSF fluid. They used the same dosing, 10 milligrams per kilogram every 2 weeks as that 2B trial. Just to keep in mind, the other monoclonal antibodies are monthly. So every 2 weeks is a lot of patient burden having to come in for infusions every 2 weeks. And this was across 235 sites. Look at this. These are monumental tasks to get these things done. And it was done during the pandemic. This drug and the next drug were done during the pandemic. Can you imagine trying to run these multi-center trials during a pandemic and not having dropouts? So a lot of dropouts might have actually been from COVID. They randomized according to whether it was MCI versus dementia. They randomized according to whether they were on cholinesterase inhibitors in the MAN team or not. I couldn't tell. You have to dig deeper into the data. You know, were more patients put on these drugs after enrollment? Were they allowed to be put on or not? I couldn't tell. And if they could, was it disproportionate? They looked at APRO, lipoprotein E. They looked at region, CSF biomarkers, and plasma biomarkers. So they did some serial blood testing for plasma biomarkers. I think this is a really important sub-study that they all have to do, because if we can ever get a plasma biomarker, that's a quantum shift forward. That's a game changer. If you don't have to do PET scans and CSF studies to diagnose this, to show amyloid load, that's huge. But it has to be very specific, meaning if it's no false negatives. If you're positive, you're really positive. They don't take someone with low amyloid and incorrectly label them as high and put them on a expensive, maybe dangerous treatment. So it has to have high specificity. voluntarily people could join longitudinal studies for PET amyloid, PET tau, and CSF studies. So this was voluntary for PET amyloid tau. You'll see in the next drug, everyone got PET amyloid and tau. It was more regulated. So the primary endpoints here, and I'm going to get into the outcome measures so you understand this better, is at 18 months, the clinical dementia rating sum of boxes, primary, changes in amyloid on PET, ADAS-Cog 14, I'm going to talk about that a little bit, the Alzheimer's disease composite score, and then this long one, Alzheimer's disease cooperative study, activities of daily living scale for mild cognitive impairment. It's a long name. So when we're looking at this, I'm going to give you MCIDs the best we could find. Thank you to Dr. Santos and Della Malva for helping me find these. But we don't know if these are correct, right? We really have to do MCID research and dig down. If you look at it and you see an MCID of 1 point on a 200-point scale, you're allowed to question that. That may not have face validity. And remember, the MCIDs don't counterbalance for cost, time, and risk. They can't because they weren't developed within the trial. So CDR sum of boxes, I like this scale. So this is a semi-structured interview to patients, caregivers, 75 items, takes 25 minutes, touches on cognition function, has 6 domains: memory, orientation, judgment, problem solving, community affairs, home and hobbies, personal care. Each was scored 0 to 3. So 6 times 3 is 18. So scored on 18. So it would look like this. You'd have the domains on one side, and you'd be scored 0, no effect 0, question 1.5, mild 1, moderate 2, severe 3. I like this. This is a sort of a very sensible scale. So the difference between the two groups at 18 months was 0.45 on an 18-point scale. So I'm going to get into that, but just look at this. This, like all the other charts that we're going to look at, show ongoing decline. But it is slower. Almost all the charts show some impact. Removing amyloid does something good. Does it do enough good to merit the risks and the cost is going to be the question. It also tells me that amyloid is part of the problem, part of the issue, but it's not the only cause of this problem. So I'm not sure we should throw away the whole amyloid hypothesis. I think it's doing something here. So change of 0.45 on an 18-point scale. In the article, they said a definition of clinically meaningful effects has not been established. But in fact, when we look, sorry for not putting the reference here, an MCID for the CDR sum of boxes has been published as 0.98 points for MCI, 1.63 for dementia. In fact, looking at the next drug, Trailblazer, has used minimally within patient change, which I think is MCID, for MCID 1 point, so that's equal to the 0.98, very similar, and 2 points for dementia. That's pretty close to the 1.63. So we're getting some concurrence. Based on this, the Clarity Alzheimer's disease trial didn't pass the MCID for CDR sum of boxes. In my mind, I'm thinking of some of the old dementia trials where I look at the responders, and even within the responders, there are mild, no responders, minimal, moderates, super responders. The old responder analysis, in my mind, starts to pull out subgroups within the responders. I don't think you'd ever approve a drug based on responder analysis. It tells you you don't have a fully enriched population. There are other subpopulations you haven't tapped into yet. So it didn't meet the MCID for CDR sum of boxes, but there was a statistically significant difference. Amyloid, with all these monoclonal antibodies, a lot of amyloid is removed. But remember, a lot of amyloid is removed. They do a great job of doing that, but there's ongoing decline. So as I said before, that tells me that amyloid is not the only cause for the ongoing decline. ADAS-Cog 14. So we're in the old dementia trials, we're familiar with ADAS-Cog 11. That's good for moderate, severe dementia. ADAS-Cog 11 they found wasn't sensitive with mild dementia and MCI, so they added some questions. 2 questions for ADAS-Cog 13, another question for ADAS-Cog 14. So ADAS-Cog 11 was 70 points, 13 was 85 points, 14 was 90 points. What they found after 18 months is a 1.44 point difference on the 90-point scale. So once again, you go, that doesn't look like a lot. We don't have an MCID, we couldn't find one for ADAS-Cog 14, but for ADAS-Cog 11, the MCIDs that have been published are 2 points for MCI and 3 for mild dementia. So the ADAS-Cog 14 would not, the 1.44 points was not as much as the MCID. It didn't cross that. Is it valid to take an MCID from the ADAS-Cog 11, apply to the 14? I honestly don't know. It's the best we could do for now, but it's just to give you kind of a sense of where the cutoffs should be. This is the ADCOMS. The ADCOMS is kind of a computer-generated score. So what it does is it takes some questions from ADAS-Cog, MMSE, CDR, sum of boxes, and it gets a score on those questions, and it multiplies them by these factors of 0.008, 0.017, and it creates an overall score from 0 to 1.97. So on this composite score, the difference between the groups was 0.05. The MCID that's been published for ADAS-COMS is 0.05 for MCI and 0.1 for dementia. So it didn't cross that bar for dementia, but it did meet the bar for MCI. So maybe that's a positive finding from an MCID point of view, MCI/MCID point of view. So a lot of these things are just below the bar for MCID, just crossing the bar very, very close. In this scale, 0 to 53 points, the ADCS, MCI, ADL, the difference was 2 points. There's no MCID found. 2 points on a 53-point scale, maybe it's clinically meaningful. It's hard to tell, but certainly the two arms are diverging over time. Side effects for this drug, for lecanemab. So 14% of people on the drug had serious side effects, 11% in placebo. So some of the side effects on the monograph were seizure, status epilepticus rare, but we have to be aware of it and be prepared for it. Headache, confusion, vision changes, dizzy, nausea, gait difficulty, focal neurological deficits. If you have any of these, you need an urgent MCI. If this was in practice, you have to go straight for an urgent MRI. Deaths were 0.7, 0.8, about the same for the two groups. No deaths attributed to lecanemab. In donanemab, 3 deaths were attributed to the drug. So these drugs, can be quite dangerous. They had a lot of infusion reactions. 26% of patients on the drug had infusion reactions. If you ever give this, you have to be prepared for these infusion reactions. So fever, flu-like symptoms, nausea, vomiting, hypotension, hypertension, oxygen desaturation. So you may need capacity to bring people to the emergency department for some of these patients if it doesn't pass. It decreases your lymphocyte count. It increases your neutrophil count. So you might get a lot of, signs that maybe the person has an infection. Serious infusion reactions in 1.2% of people. The infusion reactions could be decreased by taking NSAIDs, antihistamines, and glucocorticoids. So quite significant. 1 in 4 had infusion reactions. Amyloid-related imaging abnormalities, which we'll affectionately call ARIA from now on. So there are 2 types. There's ARIA edema or sulcal effusion, and ARIA hemorrhage, or ARIA E, ARIA H. So the edema was much more common with lecanemab, so 12.6% versus 1.7 on placebo. So it can occur with placebo, just much more common. Mostly asymptomatic early, and it passed within 4 months. 2.8% symptomatic, so headache, visual disturbance, confusion. You have that if you're giving the drug, you need an MRI. Serious, quite low, 0.8%. Hemorrhage, microhemorrhages, macrohemorrhages, siderosis, which is iron deposits from bleeds, about double, 17% on the drug, 9% placebo. So can occur spontaneously fairly often, 9% on the placebo, and double on the drug. The main symptom was dizziness for that. And macrohemorrhages, 5 on the drug and 1 on the placebo. So in most of these trials, when you have a macrohemorrhage, they just tend to stop the drug. So their conclusions were cautious. It removed a lot of amyloid, moderately less decline. So this is not a cure, right? And the amyloid after will reaccumulate. This is slowing down the loss, which I'm going to argue may be a valuable outcome. Longer trials warranted. In fact, there are longer trials going on. There's a longer phase 2 trial, and 2 4-year trials are underway. So there's more information coming. And you keep seeing the curves diverge. So maybe it's a matter of time before you see better and better outcomes. But it's hard to keep these people in these trials for a long time. There's a lot of dropout. So approval in the US and Canada. So lecanemab was approved in the US in July of this year. Remember, there was a phase 2b trial, but it was only positive really in the highest dose, the N28 group. So that's not a lot. And phase 3 Clarity trial had a few positive findings, some that didn't cross the MCID. So is this another situation where they're taking a phase 2, phase 3 trial, or they're saying, horrible disease, we're going to take a phase 3 trial, and then we're going to wait for a confirmatory phase 3 trial after release? I don't know if that's what the US did, and I don't know what Canada is going to do. It's expected that Canada may approve this in March of next year. So this stuff is coming. And drug number 3, donanemab, phase 2 trial in 2021. I didn't really understand this phase 2. They had one dose, 700 milligrams for 3 doses and 1400 milligrams after. So it's not dose finding, it's not maximal tolerated dose. It's called, I don't know what kind of a phase 2 trial that is. That's the exact dose they used in the phase 3 trial, Trailblazer. So it's the same dose, which is what you like to see. Phase 2, you find a dose that works, use it in phase 3. The N was 131 for taking the drug, which is small still compared to phase 3. Phase 3 tends to be 850 in the treatment arm. And you're going to see there's some negative findings, but you can have negative findings when you have a small N. So you can get what's called type 2 or beta error, meaning even if a drug's positive, even if it has a positive effect, you'll get a false negative finding because you don't have the sample size. So you could have negative findings just due to small sample size. As I said, I'm going to fall on both sides of this issue and go back and forth and confuse you completely as to where I stand. The primary outcome was the Integrated Alzheimer's Disease Rating Scale, 0 to 144. So 144 points. The difference was 3.2. 3.2 points on 144 doesn't sound great. In Trailblazer study, the phase 3 study, they called the meaningful within patient change, or MCID, 5 points for MCI and 9 points for dementia. So if you use that metric, the 3.2 points did not cross the MCID threshold. But once again, that could be low sample size. That could be phase type 2 or beta error. The secondary outcomes are mostly negative. That could be type 2 error or beta error also. So it might be due to the sample size. Then the big study that just came out. So the results were released in July 2023 at the Alzheimer's Association International Conference. Dr. Frank and Dr. Thomas were there. They're telling us this is coming out. Karen and I actually met with Lilly before this to show them our facilities. I was quite impressed with the fact that they knew nothing about the results. The company has really kept at arm's length from the study. So they had to go to the conference to find out what happened with the study. That's the way it should be. And then it was published in August. So another massive trial, 277 centers in 8 countries run during the pandemic, right? Imagine the dropouts from COVID, even for your staff. Like that's just a nightmare. So take the same population, early Alzheimer's, MCI versus, and early dementia with tau pathology and amyloid pathology on PET. So they focused a lot more on tau pathology here. They gave the drug every 4 weeks, so not every 2 weeks like lecanemab, so every 4 weeks. And if there was enough amyloid removal from the brain, they actually switched people on the treatment to placebo. So they didn't keep removing amyloid. That could decrease side effects. If you could reproduce that clinically, then you could actually decrease costs. They tried to balance cholinesterase inhibitor and memantine use. As I said, I don't know, was there differential in whether a lot of these drugs were started just before the trial? Was it different between the groups or during the trial? I don't know if they were not allowed to use the drugs or allowed to use the drugs. Need to dive deeper into the data. Wasn't very representative. 91.5% of the study population was white, age 60 to 85, so nobody over 85, MoCA 2028. They had to have amyloid pathology and tau pathology on PET scan. They excluded people with amyloid-related imaging abnormalities of edema. So edema fusion, you're out. More than 4 microhemorrhages, more than 1 area of superficial siderosis, so that's iron deposits from past bleeds. Any intracranial hemorrhage more than 1 centimeter. And the last one's interesting because this might be a future exclusion criteria, severe white matter disease on MRI. So they gave them the exact same dose as you saw in the phase 2 trial, 700 milligrams for 3 doses and 1400 milligrams every 4 weeks. Remember, lecanemab was every 2 weeks. If the amyloid level really drops, so I don't know what a centraloid is, but dropped to 11 centraloids on 1 PET or 25 on 2 PETs, then you were switched to placebo. As I said, if you can reproduce that in clinical practice, it means shorter courses of treatment, less side effects, and less cost. They looked for the imaging abnormalities on MRIs at 4 weeks, 12 weeks, 24 weeks, 52, 76 weeks. In infusions, if they found abnormalities, infusions were held till the edema resolved or the hemorrhage stabilized, and if there was a macrohemorrhage, they stopped it. So a lot of outcome measures, 24 outcome measures. Any researcher, when they see this, they just flip. They go, you keep doing this many outcome measures, you're going to find some positives just by chance. But there's a strong signal. So I'm going to walk you through these outcome measures one by one. But of the 24, I don't know what a gated outcome measure is. I tried to look that up. But of the 24, 23 were statistically significant, we're getting like a big signal here. There's something going on. Now, is it enough of a signal to merit the cost, the risks, and the side effects? But these are very, very consistent signals. They looked at low, medium tau versus high tau. And the high tau, this is more in post-hoc analysis, but the high tau didn't really respond very well. Most of the response was in low, medium tau. So I'm going to focus on the group. So high tau, so your tau reading, maybe one day might be an exclusion criteria. You have high tau, you're not going to get the drug. So the IADRS scale. So this is a combination of two scales. They take questions on cognition function from the ADAS-Cog 13 and the Alzheimer's Disease Cooperative Study Instrumental Activities of Daily Living. So it's a combined thing, 144 points. On this, at 76 weeks, they saw a 3.25 point difference on a 144 point scale. So that doesn't look like a lot when you're thinking of MCIDs. They said the authors said the meaningful within patient change, which I think is an MCID, was 5 points for MCI, 9 points for dementia. So this didn't meet the MCIDs. Once again, these, as I said before, these curves keep diverging. If you kept running the study, would you cross those MCIDs? It's a valid question. But what's interesting is this represents, and now we're going to get into a whole different way to look at these studies. This represents a 35% slowing of progression. Is that important? Or is that, relative risk reduction, which we know is dangerous, because if there's this much change, and you've changed it this much, that's not a big absolute change. So is this a good way to look at it? I think it is, but we need to think about this. On this scale, the ADCS IDL, there's 40% less decline in ability to perform activities of daily living at 18 months. That sounds clinically important. Once again, that's relative risk reduction, not absolute. CDR sum of boxes, remember that big thing I showed you with 6 domains, 3 points going across, a change in 0.67 points, as I said before. They have defined the MCID as 1 point for Alzheimer's with MCI and 2 points for dementia. So it didn't cross that threshold either. So it's not meeting the MCIDs, but if you ran it longer, would the curves keep diverging? CDR global scores, not the sum of boxes. So a CDR global score at 0 is MCI mild dementia. I would thought 0.5 was MCI. 1 is mild, 2 is moderate, 3 is severe. And there was 38.6% lower risk of progression, really going from stage to stage. So once again, it seems to be slowing down the disease. Not curing the disease, not stopping it, but slowing it down. Once again, that might be relative risk reduction. ADAS-Cog 13. We talked about the ADAS-Cog 11 being 70 points, not sensitive to mild dementia. So the added some questions, delayed word recall, number cancellation, made it a bit more sensitive. It changed 1.52 points on an 85-point scale. And as we said before, ADAS-Cog 11, it's 2 points for MCI, 3 points for mild dementia. So it didn't quite cross that boundary either. But it slowed progression 32.4%. So we're going to probably get into a debate about how meaningful that is, but debate is good. So their interpretation, they really focused on that time to event approach. They said it resulted in clinically meaningful benefit considered to be greater than 20% slowing of clinical progression on IADRS and CDR sum of boxes. I'm not sure where the 20% came from. Once again, we need to dig down into this MCID research. This is valid, it's just opinion-based. Last time we did the MCID study in 2009, a lot of MCIDs were, I think they were made up. There's no justification for them at all. So we need to dig down on how valid is this. They also looked at 38% reduction in progression on the CDR global score, delayed progression of 4 months on the IADRS, 7.5 months on the CDR sum of boxes. And they pointed out that 47% of participants did not change on CDR sum of boxes on the treatment group, whereas 29% were stable with placebo. So there seemed to be an effect in slowing decline. So they're really looking at this. And I think they have a point here. I think this is something we need to look about and talk about more. Radiological changes removed a lot of amyloid. So at 24 months, 34% of amyloid was cleared, 34% of patients with amyloid clearance, 76 months, 80%. The tau wasn't cleared. They thought it would be cleared, but it didn't show a difference, and that wasn't consistent with previous studies. So they're going to look at that some more, and I don't know a lot about that, so I can't answer questions about that. Volumetric MRI, the brain shrunk. And then the ventricles got larger. So when brains shrink, ventricles get larger. We know that. So there seemed to be a note of surprise in some of the papers, which surprised me, because when you take material out of the brain, it should shrink. Maybe I'm being overly simplistic. When you take material out of blood vessels, maybe they bleed. But maybe I'm being overly simplistic. But the brains did shrink. Is that a concern? Does that change the anatomy of the arteries and the veins? Are they being stretched? Can this cause bleeding? Can this have side effects down the road? Can you have more spontaneous subarachnoid hemorrhage, subdural hemorrhage? So following these patients over time is going to be critical. Side effects, a lot of edema and hemorrhage. So in the treatment group, 205 patients had edema, so that's 24%, 1 in 4. So if this is happening clinically, you're going to be sending a lot of people for MRI if they're symptomatic. If they're not symptomatic, you won't know. So 52 were symptomatic, 52 would have gone for MRI if this was in clinical practice. So 205 in the treatment group, 18 in placebo. So it can happen spontaneously, much, much more common, like 10 times more common with the drug. It tended to be mild. 13 participants had serious edema. Hemorrhage, microhemorrhages and hemosiderin deposits, 31% treatment, 13% spontaneous in the placebo. So it happens quite commonly, spontaneously, and it's much more common on the drug. And major hemorrhages, like greater than 1 centimeter, 3 on the drug and 2 on the placebo, not a lot of differences there. Infusion reactions, 74 participants. So if you're giving this clinically, you have to be prepared for that. Serious 3, anaphylaxis 3, but most of it wasn't sort of severe anaphylaxis. 3 people died in the donanemab group and 1 in the placebo group. They attributed the 3 deaths in the donanemab group to the medication. And these 3 participants had serious ARIA. I can't remember if it was edema or hemorrhage or both. 2 of them were ApoE heterozygotes, and 1 was a non-carrier. So ApoE status doesn't predict that 100%. And the million-dollar question is always, were there an anticoagulants, antiplatelet agents? And these 3 patients weren't. So conclusions, their conclusions, among people with early symptomatic Alzheimer's and amyloid tau pathology, donanemab significantly slowed clinical progression at 76 weeks. They did post-hoc analysis of high tau groups. As much as we hate that, it did show very little improvement in the high tau group. I think that group really diluted out the results. The low medium tau groups are the ones that had the most benefit. So it suggests that's the group we need to focus on. And that also suggests as you get more tau, maybe you have more progressed disease. So once the damage is done, you can't really go back. So this is expected to be approved in the US in 2024. It's going to be submitted in Canada. Lily's already contacting us and meeting with us. Are we once again accepting 1 positive phase 3 trial with 1 2B trial, or is this 1 positive phase 3 trial in a horrible disease and asking for a confirmatory phase 3 trial afterwards? And that's how the Cummings really, can say this a million times better than I can, being Cummings. He's, one of the gods of dementia care. After the accelerated drug approval, a confirmatory trial is required to assess clinical benefit, and if findings are not confirmatory, the drug can be withdrawn from the market. My question is, will it be? That would be a political firestorm once it's in standard practice. So this may be a slippery slope. I can understand, but maybe it's not a great thing. You're going to see a lot of trailblazer studies come out. There's going to be trailblazer extension, 4 trial, that's donanemab versus aducanumab, 3 trial preventing symptomatic Alzheimer's, a registration trial, and Alzheimer's 6 trial looking at MRI sequences, blood-based biomarkers, different dosing. So getting close to the end, the Videra put this well. There's slightly less worsening. It's a subtle way of putting it. I think there was less worsening, and it's small when looking at an absolute value. So that's the group-to-group comparisons, which are one way, that's our standard way of looking at it, but maybe it's not the only way we need to look at these trials. However, slowing progression by a quarter to a half a year allows for someone to remain in MCI or mild stage dementia for just that much longer. 47% were stable based on CDR sum of boxes at 1 year compared to 29% of placebos. For some, this could be clinically meaningful. So the time to event approach or transition to next stage may be clinically meaningful. Maybe it's not group-to-group comparison. And even within the group-to-group, as I said, responder analysis in the old day picked up, even in the treatment group, there would be various level of responders, which we can't get in the overall averages. Widera points out we need more data to look at unanticipated harms. Is the shrinking of the brain going to cause problems down the road? Pointed out that the exceptional ability to remove amyloid with only the subtle effect on rate of decline suggests that amyloid is likely not the only factor that contributes to Alzheimer's disease, if I've mentioned that. Pointed out that we have a very enriched group of people in these trials, very homogeneous. In 2023, we're going to start to see a shift from the tightly controlled world of clinical trials to the real world, to different patients. Other authors have said, no, don't do that. Keep the trial criteria. Keep it very, very tight if you're going to give these drugs, at least at the beginning, so that you can control the situation. Don't open the floodgates. So there have been different opinions on how to unroll this. Rabinovici really pointed out something similar, that there was slowing of decline, looked at the IDRS slowing of decline by 4.3 months, CDR sum of boxes by 7 months. And in his words, or her words, presenting the drug's clinical effects in measures that are understandable to patients, such as transition in disease states or time gained, will help inform shared decision-making regarding the meaningfulness of benefits for individuals as weighed versus the risks and costs of treatment. So time to event approach is something maybe we need to look at. Can this be built into decision aids is a question that comes to mind. Highlighted that we need blood-based biomarkers. So this would be a game changer. If we could measure amyloid load through the blood, not amyloid PET, not LPs with CSF studies, massive game changer, but it has to be specific. It has to, if you're shown to be a high amyloid on the blood test, you have to be close to 100% correct. You can't have people with low amyloid be falsely labeled, so you can't have false positives. The risk of edema was higher in people who were heterozygous for ApoE, 22%, homozygous, 40%, compared to non-carriers, 15%. So ApoE genotyping is recommended to have the risk. So if you're going to get consent, you should know the ApoE status, and maybe that can be built into decision aids or even risk calculators. So as I said, I'm wondering whether we're measuring the right thing. Is group-to-group comparison the only way to look at this? If, is responder analysis something that we should go back to? The FDA seems to hate it. I don't understand their rationale. I've read up on it. There are pros and cons. You don't make funding decisions or approval decisions on responder analysis. It just tells you within the treatment group, there are different types of responders. You need to learn more about them. But should we be looking at time to event? Delaying progression, is that clinically meaningful? And I think it can be. Then something struck me. We're talking about delaying progression for 4 months, 7 months, maybe longer. If this was oncology, how would we react? We'd be funding the drug, right? So do we have a different threshold for dementia than we do for oncology? So people may disagree with me there, but it just struck me that, in oncology, we'd be jumping all over this. This would be all over the newspapers. So you see me go on both sides of the issue, right? I'm not even balanced. I'm completely unbalanced going in both directions. These are measures, time to delay, going from one stage to the other, time delaying progression, something people understand. They're not going to understand the ADAS-Cog13. Doesn't mean anything to them. It lends itself to decision aids. Ottawa has one of the leading decision aid groups in the world. So the Ottawa Hospital Research Institute has a patient decision aids research group, which was founded in 1995 by Annette O'Connor, who is the sister of our own Liz Lacasse, who is taping this or recording this session. So if you want to learn more about decision aids, they're decisionaid.ohri.ca. I think decision aids are something we'll need, because MCI, can you create an MCID that takes into account the costs, side effects, inconvenience of the drugs when it's different for different drugs? Probably not. You probably have to build that into a decision aid. And should we be starting to look at survival analysis? Now, people may attack me for saying this, but that's what we're here for, to have a healthy, robust debate. We also have to have perspective. This is not going to treat all of our patients. So here I'm going to get pushed back to the FDA. They go, this is a horrible disease. We have to give it accelerated approval. There are millions of people who have this disease. We have to help. This is only going to help a very small minority of patients. So if you look at people who have MCI, only half of them are positive for amyloid PET. Dementia, 70%. The Mayo Clinic study, thank you for forwarding that study, had 237 patients with MCI mild dementia with an amyloid burden. If they applied lecanemab's inclusion-exclusion criteria, it would have taken those 237 patients down to 19 or 8%. If they applied aducanumab's inclusion-exclusion criteria, it would have taken 237 down to 12. So there's a real funnel, and clinically we need to have filters, right? At the primary care level intake, we cannot assess thousands of people who are going to be asking for these medications. That's not possible. But keep in mind, this is a small minority of patients. It's an important treatment. This is the future. But we also have to have a discussion about this. Healthcare can be a zero-sum game. There is not more money floating in the system. There's less money floating in the system. Will this treatment for a small minority, maybe 5% of people with Alzheimer's, draw attention, funding, resources away from the other 99% of dementia care? Will it suck the air out of the room and the money out of the room? That's a worry that at least has to be managed. These drugs cost $20,000 to $30,000, but that's not the whole cost. There's a cost of infrastructure, nurses, doctors, MRIs, PET scans, training, LP, CSF analysis, which I think right now has to be sent to BC for going to the ED, admission to hospital, admission to neuro ICU, repeated cycles. So they're expensive drugs in an area that's underfunded. So we do have something to worry about here. A lot of research opportunities here. Reviewing MCIDs, developing enhanced MCIDs, developing decision rules that can factor in balance costs, risk side effects, maybe even risk calculators, filtering, funneling things. So starting with filters that can be applied at primary care, then maybe up the intake. Might be things like advanced dementia. If you're past mild, you don't qualify. If you have severe white matter disease, you don't qualify. Anticoagulants, I don't know. Recent brain injury, recent hemorrhage, cancer, seizure disorders, other comorbidities. If you have coronary artery disease, CHF, and you're going to be in and out of hospital, you're not going to finish the infusion trial. So maybe you shouldn't start it. ISIS, there's going to be a lot of database tracking of this, a lot of registries created, but we have an automatic registry in Ontario. ISIS collects data from all sorts of databases and could track these people to see, do they finish their cycle? Do they have repeated cycles? How many? How often? Time between? Rate of infusion reactions, edema, hemorrhage, on and off anticoagulants, seizures, use of ED, hospital, ICU, surgery. Does it delay long-term care? So there's a lot of room for even ISIS tracking over the years. Second to last slide, I think Ben Navici says it best. The field is making steady progress and gaining momentum in the fight against Alzheimer's disease. The emergence of amyloid beta targeting monoclonal antibodies may prove to be just the opening chapter in a new era of molecular therapies for Alzheimer's disease and related neurodegenerative disorders. Last slide, our discussion slide. The results are getting better and better. Health Canada is going to start approving these. Once they approve this, it's going to be all over the news. There are going to be phone calls, letters asking for this. There's going to be a lot of public pressure. I predict it's going to be presented to the public as a cure for Alzheimer's. And then we're going to get a lot of pressure for that. At some point, we will be giving disease-modifying therapies. We're going to have a split opinion. That's predictable. Some people say, you presented evidence this doesn't work. Others will say, you presented evidence this works. Others are going to say, I think we should try a few patients. There's enough evidence to take the most selected patients, see if we can get a system going. Predictable. We're going to be split. Just admit that. But there are 21, not a typo, 21 drugs in phase 3 trials. And they're not all targeting amyloid. So if you believe the amyloid cascade is not the direction to go, there are other things being tested. Whether you believe we should give these right now or not is academic. We actually don't have the infrastructure. We don't have access to amyloid PET, MRI, training to read the MRI, the ApoE4 genotyping, access to infusion clinics, the LPs. I haven't done an LP in 30 years. So do we retrain? Do we get interventional radiology to do it? If we do it, we're going to have side effects. People go to ED. It's going to happen, right? There's always a percentage. We don't have blood assays. So there's a lot of work that has to be done and a lot of partnerships that need to be built. So geriatric medicine, I'm going to boldly say we're TOH is experts in dementia care. Sometimes you got to be bold in this world. We're going to need a lot of partnerships with radiology, with neuroradiologists, maybe interventional radiology if we can't do the LPs, with the emergency department, definitely with neurology in the emerge, maybe in hospital, in the ICU, in the neuro ICU. With pharmacy, someone has to prepare the meds. Who's going to pay for the meds? With the medical day unit to infuse the medications. In the new campus, the medical day unit is going to be right. Don't have to turn off. It's going to be right beside our clinic. It's like we planned this. And then the Berea Memory Program, the patients who are going to qualify this are probably not the patients coming through geriatric medicine, although the RGP is already getting requests for these medications that haven't been approved. We're getting fax requests. But the Berea Memory Program sees patients earlier. They have the neuropsychology support to really test these patients to see are they in the MCI range or early dementia. Their patients are not as medically unstable as the patients we see. They have experience with these medications. So there are multiple partnerships that have to be made between specialties and organizations. So it's going to be a long journey, multi-year journey. We're not ready to launch, but we need to elevate the conversation, not just say these drugs don't work. The drugs work. Do they work enough? Do you have to extend the trial? Are we looking at the right outcome? Is it time to event? I'm really sold on time to event, survival analysis, as a new way to look at this and to talk to patients. So hopefully some of what I said is not covered in CCD. I hope somebody will say, I heard something I didn't hear in CCD. Otherwise, I'll be very disappointed. We're going to have Alan Wong come up and deal with the Q&A session or the discussion. So Alan Wong is our previous head of the Division of Geriatric Medicine. He is the current medical director of the Regional Geriatric Program of Eastern Ontario. Alan has agreed to lead our division in the exploration of this new horizon to see how can we in the Division of Geriatric Medicine get involved in this. So Alan's very enthusiastic about this. He's going to lead the Q&A. Liz is also going to lead the Q&A. So please don't type your questions in the chat because nobody can actually read them in this room. First time we're doing this in this room. Put your hand up. Liz will call out your name and say your name, and then Alan will help moderate whatever confusion and chaos arises.